First, we will move on to the quiz session of the day. I also welcome Dr.Edwin Fernando, sir, for the quiz. So, PGs, DM, DRNB residents and junior consultants can participate in the quiz. A question with 4 choices will be displayed and polling will start with shuffled answer. Please note that quiz participants type your answer in the chat box according to the choices in the poll with the shuffled answers. Please note that the quiz participants have to type the answer in the chat box. And there are 3 attractive prizes waiting for you. So we'll move on to the first question. A kidney biopsy was done for a 16-year-old with persistent microscopic hematuria and gradually worsening renal function. He also had sensory neural hearing loss on evaluation. Electron microscopy image of the biopsy is given. So the classic basket weave appearance in the pathology is produced by A. Duplication of basement membrane due to mutations in the collagen. B. Irregular lamellation and splitting of lamina densa. C. Capillary loop damage causing mesangial interposition. D. So the answer is irregular lamellation and splitting of lamina densa. Basket weave appearance is characteristic electron microscopy finding in Alport syndrome. Mutations in the alpha 3, 4, 5 type 4 collagen results in irregular thin and thickened areas with multilaminated appearance of lamina densa, resulting in a so-called basket weave pattern. So we'll move on to the second question. What is the recommended timing for starting RAS blockade in a male infant diagnosed with X-linked Alport syndrome via family screening? A. When the child reaches 18 years of age. B. Once the GFR drops below 60 ml per minute. C. As soon as persistent proteinuria is detected. D. At the time of genetic diagnosis or the onset of microhemorrhage. Sir, please. Over kidney biopsy for the definitive diagnosis of Alport syndrome.
Can you ask somebody to answer, then we can take it.
Okay.
You can't launch a poll, but at least we can get some opinions.
Satish sir, your opinion regarding genetic testing or kidney biopsy, sir?
No, Alport syndrome definitely is a thing for genetic testing, because they may not have early on, they may not have any much abnormalities even on the electron microscope. That abnormalities come later. So genetic testing is the one that will give a diagnosis. So if you have a child with familial hematuria, you should do a genetic test. And as we know, the yield of genetic tests is improving over time. I know Dr. Jason said that absent genetic testing does not rule out Alports. But in course of time, they might come a condition where it will actually rule out, because it is actually improved. Now, even deep intronic variants are now being selected, and they are being so deep intronic variants. Previously, they were thought that they will not cause any disease. But what happens, several of these intronic variants cause a phenomenon known as exon skipping. Because what happens is that the exon next to the intron, during transcription, it is skipped. So that one exon gets skipped on this, and the rest of the exons join together. So there is something like a missense variant, because that one particular exon is missed during the transcription. So that can also be caused by deep intronic variants. So these are also coming out. So if you don't get anything on a whole exome sequence, probably you should do a whole genome sequence if your suggestion that this is an Alport syndrome is very strong.
A kidney biopsy cannot distinguish between X-linked Alport and autosomal recessive Alport.
Yeah. Kidney biopsy can also be misleading. Some of the biopsies may be showing FSGS or something like that. So you may get especially in autosomal dominant variants.
So while the histology shows the structural damage, it often cannot pinpoint the specific mode of inheritance or the exact gene involved. So I think in modern era, I think genetic testing should be done. That's the best way.
One more question. A 30-year-old female with autosomal dominant Alport syndrome planning pregnancy. Based on the 2024 guidelines, her estimated risk for progressing to kidney failure in lifetime. again,
I
Sati
think
sir.
it will be extremely variable, no? Because
Yeah.
ADAs is not very predictable how it's going to say.
Yes.
But I think if renal function and proteinuria are not significantly abnormal, and if there's no proteinuria and renal function is normal, then probably it is safe to have a pregnancy.
Yes.
Yeah, as Satish mentioned, it is extremely variable. Most of the autosomal dominant patients have a mild course, though a small subset, maybe about 20%, may progress to kidney failure, depending on modifiers. 100% ESRD is associated only with X-linked and autosomal recessive, X-linked males and autosomal recessive patients. So the autosomal dominant is no longer considered benign because there are progressors in this group also. So the X-linked females generally have a higher and more variable risk than the autosomal dominant Alport. So the right answer here will be it's extremely variable, but generally it's less than 20% as Satish mentioned.
Yes, sir. Sir, any overlap diseases like Alport with any IgA, such patients or experience, sir?
Yeah, you can see actually if there is especially if there's a familial IgA, say family, you should rule out an Alports. And you've seen patients where one more other thing is that if you look at the biopsy, if you're doing electron microscopy, you will find that there may be some base membrane changes which are not fitting with an IgA. And also, if there is not that much of proteinuria and you see foam cells in the glomeruli, that is also indicative that this may be, that's not light microscopy, not EM. So that's all indication that you may be having a collagen 4 or Alport spectrum disorder associated with that. So these are possible. It's not common, but it's not extremely rare either. So you should be looking for these subtle hints that you may have a autosomal, Alport spectrum disorder in the context of an IgA nephropathy.
And sir,
I think it is more common than it is thought to be. I think with genetic testing, I think a more young CKDs, if you do genetic testing, maybe you'll find the subtle forms of Alports. And it's very important because choosing a donor also may be an issue. If you have a live related donor, it may be tricky at times. So I think all young CKDs where we do not know the cause, now we are proactively pushing for genetic studies. I'm of the opinion that Alport syndrome may be much more commoner than we see the classic presentation.
Absolutely.
Okay, sir.
So also, if you look at the genetic studies in the 2010s, they started doing these genetic studies in CKD patients, undiagnosed CKD, and they found 10% with CKD variants. In 2020, it was about 20%. Now it's about 30 to 40% of undiagnosed CKDs and genetic disorders. So the tribe is increasing.
Correct.
Thank you, sir, for your valuable opinion, sir. Thank you, Satish, sir. Thank you, Edwin, sir. I'll hand over back to Georgie, sir, now, sir.
Jason, a very nice talk. Thank you.
Excellent talk, Jason.
Thank you.